So now we're going to do the auscultation. And I thought I was really smart. I came up with the term thoracic auscultation. That was just about as smart as naming my private practice Feeding and Dysphagia Resources. It's like I knew what the terms meant, and some of my friends and colleagues and coworkers knew what the terms meant, but everybody else was really confused. When I've said thoracic auscultation, everybody thinks I'm talking about cervical auscultation. So the course is now called Assessing Breath Sounds in Dysphagia. Make it a little more clear. So because this is a new module and some of you are watching this as a standalone course, let me give you my disclosures. Financially, you are watching the website, and I have a long-term standing relationship with the other owner, who's my husband. I get paid. My private practice is Feeding and Dysphagia Resources, which the person at the bank gave me a funny look like, do what, huh? And parents, like nobody, they just stop after the word feeding, so it'll have another name one day. And non-financially, sometimes I talk about the rescue wedge, and I am a friend and colleague of the developer. Lately, I don't mention it as often because the FDA has said, okay, no more wedges. This wedge was fantastic, and there were never any problems with it. It was developed by an OT who is, and it helped tons and tons of kids globally, and now we can't use it that much. All right, so we got to start with definition of terms because there's a lot of confusion around that. Auscultation is the act of listening to sounds within an organ, like the lungs, which was what we'll use it for, or the heart as an aid in diagnosis and treatment. This has been going on for a long time, since 1816. It is well established as a diagnostic tool, but it's very subjective. So different words for the different sounds. It's actually, the dirty secret is that it's not well taught in medical schools. The pulmonologist knows well how to listen. The cardiologist knows well how to listen. The family practice guy may get some more time with it. It's usually the nurses and the respiratory therapists. Don't tell that we know that now. All right. Respiratory auscultation in dysphagia, or assessing breath sounds in dysphagia. Why am I trying to teach you a module on that? Because I actually started out as a nursing major, and all the women on both sides of my family are nurses, so I was supposed to become a nurse, and I got far enough along that I said, you know, this really isn't for me. But I had already been taught the basics of using a stethoscope and listening to breath sounds. So when I started working on dysphagia and treating patients, especially with silent aspiration, well, I just naturally reached for my stethoscope, and I would be listening right up here in the upper bronchial tree to see if if there was any sign that they'd aspirated. If the cough reflex isn't working, all right, but I still might hear some gurgling or some rales, rhonchi, crackles, whatever you want to call it, as we'll get into, rhonchi. And, sweetie, I'm sorry, but you got to get your dog. Come on, pay attention. But I looked around and people were looking at me funny. And they were like, what are you doing with a stethoscope? I was like, well, I'm listening. I'm listening. They said, I don't know if we can use one of those. Yes, you can. It doesn't take a special license. It just takes learning how to listen. So what I'm going to teach you, I'm going to go over some of the basic pulmonary auscultation for lung status, and that's what I'll use. This is to get a fix on their overall or chronic pulmonary status. But you can find out what's going on right now in this treatment session. And that's where I started calling it thoracic auscultation of breath sounds. And this is in the pharynx and upper bronchial tree. I didn't mean to snap at you. I'm sorry. Okay, why? Well, I told you, it's basically a screening for silent aspiration. Now, if the breath sounds or lung sounds are clear, that doesn't mean they didn't aspirate. It might mean that when I put it in, I actually occluded an ear canal instead of actually being able to hear through it. It might mean that I'm not good with this. It might mean that it was traced to men and there wasn't enough to make a difference in the air traveling through those tubes. So, but if their breath sounds were clear, they chugged on a thin liquid and now they're all gurgly when I listen, that's a good clue that maybe they aspirated. Now, we can't diagnose. I can't say he aspirated because I don't have X-ray vision. But just like a nurse or a respiratory therapist, we can listen and describe what we hear. And that's what I'll teach you how to do. I'm not grinding my teeth at all. This is not cervical auscultation, and that's what everybody starts to think. And now, cervical auscultation is listening to clicks or clunks to identify movement of swallowing structures like the epiglottis opening and closing, or the UES opening and closing. That is not what this is. In fact, with cervical auscultation, the jury's still out there too as far as research goes. We're not totally sure what we're hearing. So that's why I'm not going with this. There's just some more stuff there about cervical auscultation. It was interesting to me that when I was doing some research, cervical auscultation was listed in the CASA document, K-A-S-A, knowledge and skills, what's the A for? Knowledge and skills, whatever, needed by speech pathologists who are working in the NICU. And I thought, you know, gosh, I've been in the NICU 25 years at that point. And I thought, I have never in my life tried to listen to the neck on a neonate. As a matter of fact, they don't have necks. They're like this. I have a special, isn't this cute, by the way? A special neonatal stethoscope. Look how tiny that is. But even that, on a baby, on a neonate, that's would take up like this much room, relatively speaking. So first, in order to get you comfortable with the nomenclature, the vocabulary, and some of the processes, I'm going to teach you some of the basics of pulmonary auscultation first. So we have definitions, then we have anatomy, always those two. When we're talking about the lungs, the apex is the top points. On the right lung, we have upper, middle, and lower lobe. On the left, we just have upper and lower. There really is a middle lobe, but it's like tiny and wrapped around the heart. So we basically have upper and lower. The tongue bases are here at the bottom, and then the diaphragm is kind of convex going this way. This was something I didn't get taught in nursing school. Dr. Rick Rimbecki, who is a pediatric pulmonologist and my BFF's husband, taught me this, and he gave us some pictures to use. The anatomy, like when you're looking straight on, you think, Jonathan, come here. Okay, you would think you have upper lobe, middle lobe, lower lobe. That's not actually how it goes. All right, go back over there again for a minute. They overlap, right upper, right middle. Notice that's going all the way down to the lung base. And then right lower, oh my gosh, notice how high up it comes. How can it do that? Because if you look on the side view, I didn't mean go far away, honey. I just meant go out of the camera range. Thank you. All right, you're not allowed to get water.
Okay.
Looking at it from the sideways view, there's the right upper. The right middle lobe is shaped like a piece of pizza. And you can access the front, but not really from the back. And then the right lower lobe, you can't really access from the front, but it's like almost all of the back side. Isn't that wild? So I no longer say heard in the right upper lobe, heard in the right lower lobe, because I can't be sure which lobe it's in. Because turn around this way and this way. If I'm listening right here, I don't know if that really is the lower lobe, or if I'm hearing, now go this way, if I'm hearing overlap from one of the other lobes. I'm not totally sure. Maybe I'm really good and I'm hearing all the way through. Even with X-ray, and step towards me. One more step. Good job. Even with an X-ray, you can't be totally sure which lobe it's in, can you? Now, maybe the pulmonologists have some special divine knowledge that we don't. That could be, and I'll ask Rick the next time I see him. There's normal left lung anatomy. All right, so left, that seems to be the left side, doesn't it? Left lower, well, actually, now we've got all of this overlap. So which lobe are we hearing? Left upper, that seems to be the entire front, and left lower, the entire back. Maybe. Maybe. I mean, as far as listening. Okay, some more anatomy. What we're talking, when I will refer to a couple of times, I'll talk about the bifurcation of the bronchial tree. And this is what I'm talking about here. And it's not just left, right. It's left and two rights going off to upper and lower lobes. Then we just keep branching and branching and branching, secondary bronchi, tertiary, down to the bronchioles, and down then further on down to the grapes, which are the alveoli. And you always want them to look like globe grapes instead of raisins. That's one thing too. Muscles used in breathing. I'm not going to test you on these. That's there if you want to be an overachiever. What I want you to really get is normal breathing. You use the diaphragm and the external intercostals, which is the outside muscles in between the ribs, if we're translating the Latin, okay? If there's labored or forceful breathing, like an asthma attack, a sneeze, a cough, you might then pull in some more, the SCM, the traps, and so forth, even abdominal. Now, I've told you that for our purposes, we can't be totally sure which lobe we are listening to. We're not to that level. But we've still got to be able to describe where we're hearing the sound. So we will use some landmark language. On the front, so clavicles, think of your clavicles. We have midline, and then we take the left and the right and split that in half, and we have mid-clavicular lines. On the back, we call it midline and mid-scapular lines. When I was in school for nursing, we were taught to be listening at all those different spots on the front and then on the back. And we were supposed to listen for one complete respiratory cycle at each spot. That's a breathe in, breathe out. Now, when you're asking somebody to take deep breaths, and that many of them, they're going to pass out from hyperventilation by the time a student actually gets done with all of that. And I've never even had a pulmonologist listen at all of those different sites. But we were also told, don't listen over bone or through clothing. Well, if the doctor is good, he's not necessarily making them take their shirt off or whatever. If you can, that's best. But most of the kids that we're dealing with are already a moving target anyway, and getting them to take some clothing off can just make the whole process that much worse. And for what we are going to use it for, we're just going for right here anyway. I did want to point out, I think this will be coming up, use the diaphragm side. I need one that has a bell. Hold on. All right. I'm going to put it right here. So here's the diaphragm. The other side, the smaller side, is the bell, and that's for listening to the heart. For what we're going to do, you just need a stethoscope that has the diaphragm, or just use this side. Blah, 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 and then, okay, and then there's real life. Still just use the diaphragm side, but the rest of it is like, well, you know, good luck, as you're able. What are breath sounds? There are different kinds of breath sounds, and you need to learn the vocabulary for the different types. Now, by the way, I think the sound is going to be up high enough. When I start to play the tracheal breath sounds, be ready to adjust your volume. You might have to turn your volume up. Breath sounds are airflow patterns. It's sound produced by air flowing through the bronchial tubes or tissues. Thank you. There we go. The bronchial tissues through the vocal folds, the open vocal folds, going through the pharynx, and it might be causing vibration of some liquid that's hanging out in there that shouldn't be, or liquid or infiltrate in the lung tissue that shouldn't be there. There are three types of sounds. Normal, and obviously this is key, tracheal, bronchial, and vesicular. By the time we're done, you'll listen and you'll recognize those like that very, very quickly. Abnormal, which I'm going to tell it to you and we're going to completely skip it. Consolidation, like in pneumonia, atelectasis, fibrosis, absent or diminished, as in pneumonia. We're not going to get into that because we're not diagnosing those medical conditions. I want you to be able to differentiate normal and abnormal. And adventitious sounds, that's not advantageous, that's adventitious. They generally fall into two categories, and the two different categories have a lot of different names. But the easiest vocabulary, I think, is to think of them as crackles and wheezes. And so you'll learn those in just a minute. Now I'm gonna play for you the sound file of tracheal breath sounds. Tracheal breath sounds come from listening right here, the same place where we listen in cervical auscultation if we do it, but we're listening to a totally different sound. We're listening for a totally different thing. We're not listening for clicks and clunks. We're listening to the airflow. So the easiest place to hear it is right here. I'm going to play it and then we're going to practice it.
They're hearing it through your microphone, but not from the laptop.
Oh, they're hearing it from the microphone, but not through the laptop?
Yeah, I don't know.
Huh, okay. Hold on, guys. While Jim works on the tech, I'll bypass it this way. Oh. Now, I'm still going to be able to hear it, right?
Yes.
Okay. You do. You'll get it. You're good.
Yeah, but I might have to research it again. I created a multi-output device, but I don't remember where I created it. I see it right there, but where to play with it and make sure it's set up correctly. Okay, well, tell you what, let's try this and see what we get. Doesn't seem to be playing.
It doesn't seem to play. I don't see the
Okay.
visual going.
Okay, sorry.
It's all right.
Let's do it through
Through the mic?
the mic.
Yeah, just so you know, this worked when we tested it. Okay. Just a minute. Reply in the chat and let me know how well you can hear that. Do you notice that the inhale is shorter than the exhale? Okay, now what I want you to do, we're going to go back here. Jonathan, come here. If you've got your partner, now's the time. And actually, one of the first things to do is warm up the diaphragm, because it can be very, very cold. And if you just stick it on somebody's chest or on their throat, it can be a little too much sensory input. When you warm it up, you can warm it up on your hand, but don't have the earpieces in yet, or you're going to put a bunch of friction noise into your ears.
Do you need me to take my shirt off?
No, we're going to do it with clothes on, just to show that we can. And one other real quick thing. The proper way to wear your stethoscope is like this. So if you want to look cool, this is the way to wear your stethoscope. When you see the folks on Grey's Anatomy or whatever wearing it like this, that's how you know it's Hollywood and not real life. Because if you wear it like this, you're going to get a tension headache in your going up the back of your neck, or possibly, you know, decrease blood flow through the jugulars. All right, what I'm going to do in order to hear tracheal breath sounds, what I want you to do right now is to take your stethoscope, and I want you to listen on yourself first. And I'm going to try to remember to talk before I put this on my throat, because if you talk with this on, you blast out your ears. Thyroid cartilage, lateral aspect of the thyroid. Bring the stethoscope up on there and breathe, to begin with, deep breaths with an open mouth. Like that. If you have a practice partner with you, once you can hear it on yourself, then I want you to practice on them. Now I can hear that perfectly without him opening his mouth, but still go ahead and open to start. Creates more turbulence, so you can hear the breath sounds more, a little bit louder. That is the easiest place to hear breath sounds, because they're the most turbulent there and they're the loudest there. And in this particular arena, turbulence is good. How are you feeling today? Turbulent and tubular. You'll get that in a minute. All right, so pause this if you need to and practice that skill. Now, I need to go back on the PowerPoint now. So you go to the chair. When the PowerPoint comes on, you go to the chair. Thank you, honey. Now here's a vocabulary issue. Not everybody differentiates between tracheal breath sounds and bronchial breath sounds. They just consider this part of the bronchial breath sounds. We just roll with it. So in normal breath sounds, we call that, we said they're tracheal, bronchial, and vesicular. Sometimes tracheal is part of bronchial. These are heard over the trachea and large airways. What are the large airways? And up to just a little past the bifurcation of the bronchial tree. The sound is loud, hollow, tubular. It's tubular, and you'll get that in a minute, with long respiratory days reflecting the turbulent airflow. The air's rolling through these tubes because it has room to do so. Loudest over the trachea, that's why we started there, and anterior chest wall, and I'll show you that in a minute. Lower pitch and louder often means a larger airway. So low, loud, turbulent, and tubular. Those are all good things. Okay, come here, Jonathan. Oh, actually, I'm sorry. I need to play it for them first. I forgot. Hold on. As compared to the tracheal, the inhale and exhale are a little closer. They're not quite as widely separated as far as the duration, but quite as loud. But can you hear the tubular quality? Practice. Okay, now come here, sweetie. I want you to notice I'm just using a simple little $12 stethoscope from CVS or Walmart, and it works just fine. I actually have, for me, a harder time using my more expensive Littmann scope. And this one is a $4 actually disposable scope, and I hear just fine with this one too. So whereas when I was checking tracheal, I went here, bronchial, I'm going to go here and here. So first check yourself, get to where you can hear it on yourself. Now when I'm doing this on myself, I kind of have like these funky shaped ear canals. I know that I do because I received that as an official diagnosis from an audiologist one time when they were trying to check my hearing and fitting me for certain earplugs. They were like, oh my gosh, you like go back and turn funny. So when I am listening with the stethoscope, sometimes I pull down a bit right here, and that opens my ear canals a little better. So that's a trick that I just learned to do. I didn't read it anywhere. If you are having trouble actually hearing through your stethoscope, you can email me and we can FaceTime, and maybe I can help you that way. We can FaceTime or Zoom or something. Something that I like to do, this is my favorite stethoscope, a teaching stethoscope, where I can have it in my ears, you can have it in your ears, and I can move it around, and then I can say, oh, here, listen to this, listen to that. Can't do that on Zoom, thank you, COVID. And yes, that's my phone number. So please do not call me in the middle of the night. You will wake me up, and I'm usually kind of incoherent. Not necessarily grumpy, but I'm definitely incoherent. So now, going good. Now, why would I not necessarily listen to his upper back, aside from the fact that he might still have a spinal galant reflex reaction? I can hear. It's much quieter. I'm not sure what lobe, right? So we're going to keep it up front. If you are having trouble off right now, since you're just learning, ask your partner to take their shirt, assuming. Okay. Now, I need my PowerPoint back. Good, you're learning your cues. All right. Now, vesicular. This is quiet. And in fact, once you learn to recognize vesicular, when we go back and listen to bronchial and tracheal, you're going to go, oh my gosh, that is so easy now. So vesicular is what we hear more down in here in the smaller airways, the secondary and tertiary branches. I love this, it's very poetic. The air sounds like soft wind through the trees. That's a quote from an auscultation book. Soft wind. The expiratory phase is shorter than tracheal and bronchial. Why? Why would that be? How come we're hearing differences in the phases when if the person is sitting or standing in front of you and they're going, shouldn't it be the same amount of air in and out? Basically. Because when you breathe in, all of it's going through the trachea. Most of it is going through the bronchial. Out here into the vesicular, only some of it is making it all the way down into those smaller airways. So then it comes in. Once it goes out, the expiratory part is over sooner. The inspiratory starts later because it takes a while to be getting expansion down here. And then when the air starts moving out again, it's like out and it's out. While you would still be hearing breath sounds up here because the person is still exhaling. And I think you've seen on the slides, I've got some an online resource that's free for listening to more so that you can practice this. So vesicular. That's a lot harder to hear, isn't it? Let Jim know if you can't. Okay. Come here, Jonathan. So, on yourself, easiest place, I think, is to go right here. So, under the underwire, right there. Sorry, let me change sides with you. For a minute, I thought you were dead. Okay. Pause this and practice if you need to. If you don't totally get hearing the vesicular the first time through this course, that's okay. About 20% of the people don't, and it takes a little more practice. Keep going with the course right now, though, if you're in it live, because I don't want you to miss some stuff. All right, thank you. We're going to hear tracheal breath sounds when we place the diaphragm diaphragm of the stethoscope here. We're going to hear bronchial right here. And then vesicular are out around here. Okay? Abnormal breath sounds. Now, I said we're not going to study abnormal. We're not. But I do want you to at least get this. When the airways have less air means greater lung tissue density. So it might be due to fluid, as in pneumonia or some really, really bad aspiration. Sound transmission is better. Because when there's air in between, going through the air molecules, you lose a lot in transmission, whereas if it's liquid or fluid, then you have, think about at the swimming pool. Doesn't sound, think about under the ocean, whale song. All right, but doesn't it go out like sometimes that? It's because with the greater the density, then the greater the transmission. So you will have louder, more tubular breath sounds. So in other words, the worse your lungs, the better they're going to sound, quote unquote, better out over the vesicular area. It shouldn't be easy to hear the vesicular breath sounds for us. Don't you feel better now? So it will sound like bronchial breath sounds rather than vesicular. Expiration is much louder and longer than normal. So basically, hearing bronchial breath sounds over the abnormal. And that's the point I wanted you to get here. As far as classification of terms, oh my gosh, do you not get a headache just looking at this chart? Because we can have, it's classification of adventitious sounds, and we've got coarse crackles, fine crackles. That one I'll teach you. Coarse rails, fine rails, just plain crackle, crackle. Rails, and then some other ones that I can't pronounce because they're in French, and on and on and on. Oh, we've got sibilant rhonchi, sonorous rhonchi. I'm like, what? High-pitched wheeze, low-pitched wheeze. That's the translation of sonorous or sibilant and sonorous. And then some more French. I'm going to teach you something just a little easier. First, we're going to talk about crackles, which are also known as rails, but crackles because they sound like what they are, onomatopoeia. Discontinuous and explosive sounds. It's popping. Now, we do have coarse, loud, low-pitched crackles, usually in the larger airways due to secretions or aspiration. So circle that one, all right? We have fine crackles, softer, high-pitched sounds, usually from pneumonia, and so it's down lower. The sound is actually made when the alveoli are popping back open. So let me play some for you. Coarse crackles. Let's do coarse crackles here. Hear that popping at the end? All right, here we go again. Let me play it again for you, and I'll try to make a visual when the crackles are happening. Okay. You in the live class are not getting this and you need me to repeat. Okay, so just put something up in the live chat. Jim's monitoring it. So it's basically pop, 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 pop. It's a lower, louder, generally on expiration. Now here are fine crackles, and it sounds like crackling mylar, or what is that? Rice Krispies? Sounds like that. This one's easy on this recording. Again. They're closer together too, aren't they? Because it's sort of, they're closer together because it's sort of all happening at once. Instead of pop, 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 pop. So crackles are discontinuous, explosive, also known as rails. The next one, the next adventitious sound is ronchi or wheezes. I like crackles and wheezes. Other people like rails and ronchi. A low, loud-pitched wheeze, continuous low-pitched turbulence. If you're going to get picky, we can measure it at 200 millihertz around. Sounds like snoring, and so sonorous and snoring kind of go together there. Musical. Now, I have never listened to somebody's chest and gone, that sounds to me. Some people are just, you know, they're getting a little too into their specialty there if they can use musical. This is due to something in the airway, can be secretions or aspiration. So I want you to hear ronchi or low-pitched wheeze. Doesn't that hurt you to listen to? Listen to it again. If you listened to this patient before you started your therapy session and their breath sounds were fine, and then you heard that, you need to call their doctor. My computer just shut down. All the tech guy said was, Great. We have a different outlook on this, sweetheart. All right, hang on, guys. All right, it's coming back. It is the end of 2 long days. Yes, it's coming back. I don't know why. Because everything's doing that right now. All right, here we go. You shut down your computer because of a problem. No, I really didn't. Okay. It was probably something you did. Practice on yourself. Practice amongst yourselves. says I was using Skype. I was not using Skype.
Might have been running in the background somehow.
Yeah. Okay, here we go. We had just finished Ronkai. We had done the loud. Oh, I'm ready.
Okay, you're on.
No, I'm not. I don't have on the monitors. I don't have my PowerPoint. Volume's up.
It's because you didn't start your PowerPoint.
User error. Jim used to work for Dell desktop or the call-in help center. The stories he told makes me feel much better about myself. All right, so we had done Ronkai low-pitched wheeze, continuous low-pitched turbulence sounding sonorous musical. Now, the high-pitched counterpart to that, the sibilant wheeze. It's around 400 hertz, a hissing sound. That's when there's an obstruction in the airway, like in laryngo or tracheomalacia, or asthma, or stenosis. So I want you to listen to this. Ready? And again. Now, just for comparison, let's go back and listen to the low-pitched wheeze. And now the sibilant or more higher pitched wheeze. It's more continuous. Okay. Now, do you have to differentiate between those two just because you took this course? No. You can just say, I hear something funky and I think we need to call the doctor. But I want you to recognize that it's something funky, all right? Now, stridor, it is a wheeze-like sound, but it's worse due to blockage of airflow in the larynx or trachea or aspiration of a solid. So I want you to listen to this one. This one hurts. Jim says that one is a whale song, or maybe a seal barking. Just a little bit more. Okay. you're going to recognize these because you're going to take a little test at the end of this, and you are going to be shocked at how much you've already learned. You're good. So, what are signs that aspiration has happened? Rhonchi in the smaller medium airways, rhonchi plus coarse crackles in the main bronchi and trachea. And that's more where I'm listening, because I want to know, did they just aspirate on what I just gave them right now? Often cleared with cough. And that's important. What I would do, and I actually did come up with my own little protocol, is when I was just starting using NMES with peds, I was the first person, first clinic to use it with peds in Texas. So obviously I'm dating myself. And I'm like, okay, we've got these kids with silent aspiration. How am I going to do this? And how am I going to know when they're better? If they're silent aspirators, how do I know when they're fixed? So what we would do is we would do 5 trials of 1 teaspoon of water, so thin, clear liquid. And we would do that about once a week. And we would listen beforehand and after. And once they had 3 consecutive weeks of no signs of aspiration on that, then we'd go for a follow-up modified. Because otherwise you're shooting in the dark. Like, well, let's schedule another one because I think it might be a good time. But you're exposing the kiddo to radiation. You better have a good reason, and you better be pretty sure it's time to be done. And again, this is anecdotal, but I never had a kiddo that passed my screening and didn't pass their modified. Someday I want to go back and turn that into a real study, but someday. So I liked this little quote. Somebody said to me, well, it's like Rice Krispies. You only hear the crackle after you've had the milk. Is there a direct relationship between aspiration and their oxygen saturation reading? I know that when VitalStim first came out, that was one of the things they were saying. If you noticed, several years back, they dropped that. Because when the research came out, when they did more research on it, they said, that correlation is not holding up. So, and that's something too that I've noticed in the radiology suite when I'll have a kiddo who is on O2 sat monitoring, and I'll be watching and I'm looking at the monitor and there's like dump of aspiration. The O2 sat never dropped. Sometimes they track nicely, and sometimes the sat starts dropping and the kid has not aspirated anything. But maybe they've had several consecutive swallows and they're not doing well coordinating suck, swallow, breathe, or just swallow and breathe if it's an older patient. So I like to have an O2 sat monitor on when I'm working with patients, and you can get a pediatric O2 sat monitor off of Amazon. And you can get adult ones too, but the peds ones are a little harder to find, but you can get them on Amazon. I don't rely on it to tell me, oh, probably no aspiration occurred. I just watch it, and if it does go down, then I know I need to change something I'm doing. So it's not that if it doesn't go down, then everything's good, but it can tell you, hey, something is bad here. So I want you to listen again to coarse crackles. Oop, it stopped. Listen again. Okay. Are you hearing that more clearly now each time? So if I heard that after I had introduced, say, my 5 teaspoon trials of thin liquid, or after I had been working during the therapy session but it was clear beforehand, then I'm going to go, I think they might have aspirated. So, common auscultation findings in a disorder. In chronic bronchitis, and you don't have to memorize this. This is just to give you some more context. In chronic bronchitis, so a chronic aspirator, early low-pitched inspiratory crackles and a loud expiratory wheeze. So they're going to sound bad. Pneumonia, high-pitched bronchial breath sounds, so louder and what seems to be more tubular. The affected lobe with late inspiratory crackles not cleared with cough or position change. And that is another point to make. A cough or position change, you want to note if you heard something funky, did they cough? If they coughed, did it work? Or if you sat them up, like sometimes with a little one, if you sit them up a bit, kind of pat like you're burping, but you're really kind of trying to get that stuff up, did it work? Did it get better? Now, let's go back and compare to the beginning. I want you to listen to the tracheal breath sound now and realize how differently you hear it than at the beginning of this course. It even feels cleaner. Is that not sounding tubular to you? Easy to hear, clean, no pops, crackles, rhonchi, wheezing, or music. It sounds wonderful. Some more places for practice. Okay, Jen, I can hear the difference. How am I even going to write about it? I'm going to teach you the long drawn out way, but in the end, go with your comfort level. And if you don't even feel comfortable documenting at all, don't. But go ahead and call the nurse or the doctor or sit there while the parent does or so forth. We can use the anatomical landmarks to say where we hear it. I'm not going to say which lobe, but I'm going to say, oh, you know what, I heard it at midline, or I heard it at the mid-clavicular line. If I hear it on both sides or just one side, do I think it was loud, soft, absent, diminished? Duration. Do I hear it on inspiration, expiration, or both? Do I hear it through the whole breath? Early on, late? When it says pitch, high or low, for me, I can go, that was pretty high pitched. But differentiating, like when they say the sibilant rhonchi is a higher pitch than the sonorous rhonchi, I'm like, they wheezed. It was a wheeze. But here's an example. This is how a nurse would write it. I'm not expecting you to. Bronchial breath sounds and late inspiratory fine crackles were heard over the right lung base posteriorly along the mid-scapular line, and coarse crackles were heard throughout inspiration and expiration. What's all that mean? It could be aspiration pneumonia. Okay, Jen, you've taught me a bunch of different sounds. You taught me a bunch of different words. You just told me that I'm not going to document like that. What is it that you are expecting me to do with this information? We're going to take that knowledge of auscultation of breath sounds in the lungs and auscultation of breath sounds in the pharynx and upper bronchial tree, and we're going to use it as a potential screening for silent aspiration. And we're doing this using already established procedures and knowledge base. This helps with the whole issue of evidence-based practice. We are taking something that already has a lot of evidence, even if it doesn't have a terrifically discriminated vocabulary. And we're going to say, this can give me some information that something went wrong or something might have gone wrong. You know that? Okay. Listening right here, which is where we would hear tracheal breath sounds. Things that I know could indicate penetration or aspiration, and this is already established in the literature. Normal airway sounds before the swallow, but turbulence after. And I'm sorry, I said earlier turbulence was good. Yes, depends on how you're using it. If you're using turbulent as bumpy breath sounds instead of that nice smooth in and out that we now can comprehend when listening to normal tracheal breath sounds, if it's the you know that's bad now. Increased turbulence after the swallow. New turbulence after you use Logeman's techniques to dislodge stuff that's left over, either that has spilled over or is left after the swallow, and that is saying ah, or turn the head and swallow, or trying to blow it up and out. In fact, if all you want to write is increased turbulence heard, that's all you have to put. You don't have to put where you heard it if you don't want to. Here are aspects of it that you can document if you want to. But here's some examples. And I've written this, I pulled this from some of my reports. New low-pitched turbulence noted in trachea on inhalation and exhalation after a swallow of 2 teaspoons of thin liquid by spoon. Louder at the thyroid and mid-sternal placement. So I'm saying it's louder down here than up in here or down in here. Cleared with cough. So probably had some louder at thyroid and mid-sternal, so probably started in the wrong way. They've coughed it back out. And possible residual in the piriforms. It could be that as well. Increased low-pitched turbulence noted at mid-sternum on right on inhalation following continuous straw sip of nectar consistency liquid. Not cleared with cough. So what did I do? PO presentation discontinued. If you are noting that you heard a problem and it wasn't cleared with cough, it didn't go away, you need to document that you stopped. Now here, okay, possible aspiration. Here is what you want to put. Breath sounds clear to auscultation at mid-sternal and pharyngeal placement following therapy session. In other words, you can put nice way to CYA. And that has come in handy before. I had a patient that the caregivers, the family, were constantly feeding her things, thin liquids that she had not been cleared on, that we knew she was aspirating. Now, I'm working with her in therapy. This is what I had written in my notes on Thursday, the last time in that week I saw her. Over the weekend, she was admitted through the ER to the hospital with aspiration pneumonitis. She had stuff going on. It wasn't from what I did, because I showed lungs were doing fine. Everything was fine up here when I was done with her. So, how to incorporate it into your assessment and treatment? Get a baseline. Baseline at the pharynx and upper bronchial tree. Do your evaluation or your therapy, rechecking as you go. Is there a mandatory, like check every 5 minutes or every 5 swallows or every 5 presentations? No, there's not. Use your clinical judgment on that. And then at the end of the assessment or the treatment, check again and document. Now, you can, as you get better and better at listening, pay attention to pulmonary breath sounds over the entire course of treatment. You can also, if you want to, listen for the abnormal breath sounds if you have a patient with a chronic pulmonary condition. And also, have you had those patients that they sound gurgly before you start working with them, and they've got a chronic condition that they're always going to sound gurgly, and you're saying, how do I treat this kiddo? I don't know. Are they silently aspirating? Are they not? You can baseline. You can get a feel for, okay, how much gurgle is there before I start working with you and where? And then as you work, keep rechecking. If it gets worse, then stop. Gone through that. Now, I want to prove to you how much you just learned in like 30 minutes. All right? I want to prove to you how good you already are. I want you to listen to this, and I want you to be thinking first, just, is it normal or abnormal? If that's all you get, that's fine. If you can identify what kind of sound it is, then that's even better. And if you know what that kind of sound might indicate, then you're an overachiever. Normal or abnormal? Okay. What do you think it is? All you have to put is it was a wheeze. But you knew right away that it was certainly not tracheal breath sounds, right? Let's do another one. Normal or abnormal? It was abnormal early inspiratory crackles, which could indicate chronic bronchitis. Normal or abnormal? What do you think it is? Coarse crackles. So that might be aspiration. Normal or abnormal? Normal tracheal. And I know you got that because that's the easiest one in there. Normal or abnormal? Normal vesicular. So did it sound poetic to you? Like soft wind through the trees? You were probably able to identify that you didn't hear anything funky. It was short episodes of airflow in between longer episodes of silence. That's also what's going to end up vesicular. Only a couple more. Fine crackles. You knew. Sounds like Rice Krispies. I know you've already identified it's abnormal. Is there one adventitious sound or two? Okay, if I'm even asking, then probably there's two. There was a coarse crackle on inspiration and wheeze on expiration. All right, before we finish this up, I want to say you've got to go practice. And normally we'd be going around the room practicing on different partners. We can't do that right now. Thank you, COVID. So what I want you to do is to practice on your family, practice on your roommate, practice on anybody who will let you. Probably with COVID, you go up to a stranger and say, let me auscultate you. But as many people as you can, try to listen for different sounds.
If you have them practice for another 5 minutes, they'll get an hour and a half.
Oh, Jim says, if I have you practice for another 5 minutes, you'll get an hour and a half of CEUs. Actually, since practicing is part of the activity with this, then we can say, stop it here, practice for 5 minutes and come back, and that's legal. That's legal for CEUs. All right. You know that's not normal. Can you identify which adventitious sound it is? Actually, it kind of sounds like my little dorky dachshund Yorkie dog coughing. That's what it sounds like to me. Strider. And it won't stop. Okay. Can you diagnose this one? Last one. How many of you got that one right? Okay. One last little bit of notes per Dr. Rick. If you really want the official diagnosis on that one, the inspiratory component is extrathoracic, which means you hear sternal notch. The expiratory component is intrathoracic, meaning it's below the sternal notch. That is also how you differentiate between laryngomalacia and tracheomalacia. If you want some more on pulmonary, Dr. Rick and I teach a class together called Food We Breathe. We've done a 1-hour version, a 2-hour version, and a 4-hour version, and we still keep running out of time, so it's going to become an all-day class because he talks more than I do. Just saying. Now, there's all the contact information. Again, I highly recommend that you join the Facebook group Feeder. We are so blessed to have so many gurus on there. Suzanne Evans-Morris, Nina Johansson, Christy Brackett, Robin Walsh, Deborah Beckman, on and on and on. And I'm humbled to be a part of and admin this group. So, do you have any questions? Please put them in the live chat. To answer. Thank you so much for giving me your time. I thank you for being patient with the fact that I talk so much. Have a great day. Have a great week, and have a great